We will start the second session of the WFNS Education Training Committee and WFNS Young Neurosurgeon Forum Committee. And the lecture will talk about the update of the trigeminal schwannoma surgery. We have two young neurosurgeons, Maxim Yanunred and Abidasha, will talk about the neuroanatomy of the approach, and we have expert speakers. Firstly, Mustafa Baskaya will talk about the choosing the path for the trigeminal schwannomas. Please, Professor, you can share your screen.
Okay, perfect. And is everybody seeing the screen okay?
Yes, Professor.
Yes.
Okay.
Okay, perfect. Thank you, Abuzer. Thank you, Professor Zuleli, and the rest of the speakers and distinguished members of the organizing committee. It's a great pleasure to be here. Good morning, good afternoon, or good evening, wherever you are. So my topic is the choosing the best path or choosing the best surgical approach for trigeminal schwannoma treatment. So I have no conflict of interest, and none of the material used here is all of the material used here belong to me or my lab. And trigemini means, as we know, three born together. And I'll give you guys the first brief overview about the trigeminal schwannomas. This is mostly for our young colleagues, the residents and trainees. So as we know, trigeminal schwannomas are benign tumors, consists of the less than 1% of all intracranial tumors, and is the second most common schwannoma in the head. They don't have severe symptoms. Usually they present with the subtle symptoms. Numbness and paresthesis in the face is the most common symptom. And some patients, up to the half of the patients, can have facial pain. If patient has a complete or near complete anesthesia of the face, that may indicate the malignant process of the trigeminal ganglion. These are the common findings, and it's not uncommon to find a diminished corneal reflex or absent corneal reflex, and most of them has the decreased sensation in the face. And one thing most of the patients don't notice is the weakness of the mastication muscles, especially the wasting of the temporalis muscle. They look very hyper intense in most of the time in T2 and T2 flare MRIs, except like this case, it can be iso intense on T2. Homogeneously or heterogeneously they enhance. And if you have this dumbbell shape appearance, that may indicate this is the trigeminal schwannoma. They can involve anywhere between from cisternal segment of the trigeminal nerve to the ganglion, from ganglion to the peripheral nerves, and it can present in the cranium anywhere from orbit to the brainstem. The location can vary. It can be in the root cisternal segment and the cerebellopontine angle. It can be in the gasserian ganglion purely, or extradural and the cavernous sinus in the orbit, or combination of all of these, and that consists of type 4 trigeminal schwannoma. A first classification by Jefferson in 50s. This is, as you can imagine, it's all depends on the location. He described this as a middle fossa type A, posterior fossa type B, and if it is a dumbbell shape, it's going to be the type C. It's very simple, and people try to come up with the different classifications. I find this very complicated, and I don't think we need to have more complicated things to remember. And the Dulenge classification, I think, is the one of the recent classifications. Again, type 1, type 2, type 3, and type 4. I'm going to show you some examples from these. What are the treatment options? Treatment options in general, observation in small tumors might be a good option. Surgery and or radiosurgery or fractionated radiation therapy. Surgical approach all depends on the location of the trigeminal schwannoma. In symptomatic cases, early intervention is indicated, and cavernous sinus involvement is very common, and lateral wall of the cavernous sinus even sometimes can be penetrated by these tumors. This is the type 1 surgical exposure for this is it can be terminal craniotomy, it can be frontotemporal, interdural, subtemporal, frontotemporal, zygomatic, anything you can imagine. But I think is the best way is the either just simple frontotemporal craniotomy or terminal craniotomy with peeling the dura of the temporal lobe, unroofing the orbit, as described by the Professor Dulenge. If this is actually is a typo here, type 2. Type 2 is typical for cerebellopontine angle involvement, a retrosigmoid approach, or lateral infratentorial approach, suboccipital approach is the choice. Sometimes you may want to drill the suprameatal. This is again typo here. It should be suprameatal drilling. Sami described this, as you know. And you can also use the posterior transpetrosal or combined petrosal approaches. And there's another approach, subtemporal transtentorial, which I find is quite challenging to do in these cases. Type 3 is the combination of all these like a double shape in the supratentorial and infratentorial compartment. Again, you can combine approaches, but most of these tumors in the type 3s, they perform their own autopetrosectomy, so you don't need to drill even anterior petrosal bone. Whichever approach you do, orbitozygomatic, cranioorbital zygomatic, is the main approach, is the Dulenge frontotemporal craniotomy with peeling the middle fossa dura from the rootlets of the trigeminal nerve. And it can be sometimes you may need to do 2 stages depending on the logistic reasons or anatomical, pathological anatomical reasons. Type 4 is very extensive tumor. It will involve all compartments of the trigeminal nerve. Again, here you can combine the approaches. Nowadays, many colleagues use endoscopic approaches, or you can combine open approach with the endoscopic approach. And I think Sami Youssef, not in trigeminal schwannomas, but in other type of tumors, has extensive experience with this. He can talk about this later. To understand, I think is the best way to go to the lab. This anatomy, it doesn't come to you just reading and watching. You have to go to the lab and dissect. And these are the beautiful dissections by my fellows and by Professor Emel Avcı from Turkey. She commonly comes and visits us and directs these dissections beautifully. And this is her recent dissections. It shows the entire anatomy. It's beautiful, and you have to perform this in the lab. Without performing this, understanding this anatomy becomes an issue. And you have to take this lab to the operating room. That's the key. And this is one of our courses. I am performing this dissection. Orbitotomy is already done. You don't need to do orbitotomy, orbitozygomatic approach or cranioorbital approach, but you need to drill some part of the orbit to dissect. And now we are unroofing the supraorbital fissure and lesser wing of the sphenoid wing drill down all the way down to the clinoid process. And then that extradural dissection starts, peeling the dura propria of the temporal lobe from that membranous layer of the cavernous sinus. Sharp dissection, blunt dissection techniques, or combination, we start seeing the trigeminal nerve V2. And now I'm finding the foramen spinosum and middle meningeal artery. You need to coagulate and cut. When you are cutting this, you should be careful. And now I'm putting the state sutures of Dolench. Dolench introduced this technique. So you are peeling that dura you dissected and away from your view. And that's the optic canal. Now this space becomes a very deep space, becomes a very shallow space, and an entire clinoid is isolated. And now we're going to start the clinoidectomy with the optic unroofing, and then move to the clinoidectomy. We're going to hollow the clinoid process, and clinoid process has a bone marrow. And right here you see that bone marrow. You are doing fine, and you can use cutting drills or coarse diamond drills, whichever one you use. And then you fracture the optic strut, and that's the optic strut right now. And then you move, that's the sphenoid sinus mucosa. If you take this optic strut, you're going to end up in the sphenoid sinus. Now we are coming to the intradural dissection, optic nerve. This is clinoidal ICA. This is supraclinoidal ICA. And you see the ophthalmic artery. And when you are dealing with the optic strut, you need to be extremely careful with the ophthalmic artery. Dura in that region is closely attached to the ophthalmic artery. And you see that's going to be the, I believe, oculomotor nerve. Now I'm further dissecting the distal dural ring and excising the distal dural ring. That's the posterior clinoid process. You start seeing the oculomotor nerve. We're going to unlock the oculomotor nerve, and by cutting it, then I'm going between oculomotor and the fourth nerve. Fourth nerve is isolated, and this is the tentorial edge. Now this is going to be a Parkinson triangle between 4 and the V1, and that's the C4 segment of the ICA. As you see, this is the Gasserian ganglion, and when you get the CSF here in the real life, you know that you are in the Gasserian ganglion. And I move to the fourth nerve here, and you see cisternal segment of the fourth, and then going through the tentorial edge. And now we find finally the sixth nerve at the deep part of the between carotid and the V1. So this is just to show you this exercise, and this is very abbreviated summary of it, but you can do these, and my dear colleagues Abida and Maximiliano will talk about these things. And then adding the petrosectomy, anterior petrosectomy or Kawase approach is an option if the autopetrosectomy was not done by the tumor. Sometimes autopetrosectomy is done by the tumor, sometimes minimal. You can extend this with further drilling all the way back to the internal acoustic canal. And some tips, if dissecting the greater superficial petrosal nerve can be challenging sometimes, I find the isolating it anatomically first, and then confirming that with the facial nerve stimulation of the geniculate ganglion. If you think it's going to avulse the nerve, please don't do that. Just cut it, and the result will be dry eye, and the rest is all we know. And then this is the case example of a type 1 trigeminal schwannoma. Incidental finding, patient was young. I recommended the surgery and he accepted to proceed with surgery. This is completely extradural approach and terminal craniotomy, exposing the clinoid, exposing the V2, V3. I just drilled the bone over the foramen ovale and foramen rotundum. And then I'm going between V2, V3, removing piece by piece. If the tumor, if the trigeminal schwannoma, one note, I encountered this case, and I also observed Professor Dolench real time. He told me that he had two cases like this. If the schwannoma is very firm, very hard, not easily dissectable, as you know, any schwannoma will be soft and yellowish in color. If it is very hard, very firm, uh, uh, he said that that's usually the sympathetic chain schwannoma, not the true trigeminal schwannoma. And this is the one case I encountered. It was as you notice at surgery video, it was very firm. And you cannot make the exact diagnosis, but that's my assumption. Again, in this case, probably this was not true trigeminal schwannoma. It was a sympathetic chain schwannoma. So this is a type 3. I don't have the case example of pure type 2, just cysternal segment. You can do the just retrosigmoid craniotomy. Uh, but that's straightforward, and Sami is going to talk about that with suprametal or without suprametal drilling. So this is an example of an elderly patient presented with the sixth nerve palsy, cognitive dysfunction, because you see there's a hydrocephaly from the compression of the pons and the fourth ventricle. And and as you see in the CT scan, the bone is eroded, expanded here, and there's a tiny cortical layer here. So this is anterior petrosectomy almost performed by the tumor. Okay, so this is again frontotemporal craniotomy, cutting the meningoorbital band or frontotemporal dural fold, isolating the anterior clinoid process, peeling that, and then you start with the small orbitotomy. You unlock the supraorbital fissure, complete the anterior clinoidectomy. Then you come to the Petros's ridge. You find this is that eroded bone of the anterior. I'm sorry, it's very short due to the time concerns. And then you make opening between cranial nerve, isolating the ICA. It is rare, but you always good to confirm. As you notice, this tumor is way softer than the initial case I show you. And then we're gonna go towards the clivus. We're gonna cut the superior petrosal sinus. In most of the cases, these large cases, superior petrosal sinus is obstructed by the tumor. So you don't have to just worry about it, but if there's a bleeding, you put the clips and cut in between, and then you cut the tentorium. Now we are in the infratentorial compartment, and then you go one by one and remove it. So the retractor here is holding that dura I dissected, and the rest is subarachnoid dissection. And every time, whatever technique you use, at the end, you use the arachnoid dissection techniques introduced by Professor Yaşargil. So this is the end product. Very good outcome. Patient experienced improvement in his exam and did perfectly fine and has been tumor-free since. This is another case. It's type 3, same approach as I show you, and we achieved the gross total resection. This is type 4, very extensive tumor going to the orbit, causing proptosis and a dumbbell shape involving every segment. So this is the same approach I did. I'm going to skip for time concern reasons and achieve the gross total resection. Even 86-year-old patients, if patient is healthy, you can perform this kind of surgery. And most of the surgery is extradural, and they tolerate these surgeries very well. This is a 86-year-old farmer Northern Wisconsin, did very well and very happy. He's very active still, almost 3 years now. So in conclusion, with the current skull-based techniques, actually, even with the cavernous sinus involvement, either you use endoscopy or open surgery or combination, the success rate is much better. And then if you achieve gross total resection nowadays, the recurrence rate is not that high like used to be. And we can achieve much better gross total resection. They initially, when they present with the cranial nerve 5 dysfunction, this can get worse immediately in the postoperative period, but they get better. And even if they don't complain that much. Important thing is the preserving the adult cranial nerves, 3, 4, and if you do that, they will be very happy. And but yes, there are complications, CSF leak, and if there's the one of them because you are combining in some of these cases supra-infratentorial approaches, so you just get a fat, abdominal fat, and the putting the lumbar drain is also very helpful. Retraction of this dura temporal lobe, and also you can use the lumbar drain at the postoperative period to prevent the cerebrospinal fluid leak. And the other complication is the complication inherent to what we do every day. In summary, gross total resection is the treatment of choice, my choice. Surgical approaches are all depends on where tumor is located. And extradural skull-base approaches, Dolench approach, or whatever you call it, Hakuba approach, or combination of these anterior petrosectomy increase the success rate. But if the tumor is simply located in the cerebellopontine angle, just retrosigmoid approach, like a simple, straightforward, to me, like the simple terminal approach and retrosigmoid approaches, both approaches are the workhorse of the skull-based surgery or intracranial microsurgery. And then nowadays, endoscopic approaches can be used, and there are different variations of this. And radiosurgery can be also used in recurrent residual, or in some cases for any reason, surgery can be risky due to the medical condition of the patient. In summary, I think we intracranial neurosurgeons, we should be familiar with the thorough understanding of the cavernous sinus anatomy, and that means you need to spend time in the lab. So anatomy allows you to localize the tumor and then to choose the correct surgical approach. And this is the Winkle's saying, and I wholeheartedly agree with him. He's our leader in the cavernous sinus region and pioneer, and he opened a new era operating on these. And we should be, not only my generations after me, and even younger guys should do much better and be very versatile in these approaches. So best way of learning is teaching. Go to the lab, listen to these webinars, watch the videos, read, and most importantly, go dissect in the lab. If you do that, you will understand and you'll do much better. And I'll invite everybody to the first Congress of Yaşargil Microneurosurgery Academy, which will be held in Istanbul between June 4 and 7. Any younger colleague, less than 40-year-old, who submits an abstract, and abstract is accepted, will give the free registration. And this will be a wonderful event. Again, I appreciate the invitation, Professor Zileli, Professor Güngör. Thank you very much for having me, and distinguished speakers and all the participants. Thank you for your time.
Thanks for your excellent presentation. I learned too much, as always. And There's no question from attendees, but if there anybody to ask or discuss anything. Also,
I
Professor
would
Sami
like to.
Yusuf.
I
Okay.
would like to ask to Professor Baskaya. He talked about the subtemporal transtentorial approach, and he said in some point is sometimes it's a challenge. I would like to learn from him. What is your opinion about that approach in some cases?
Yeah, I mean, you are not relaxing the brain, right? And you are a lot of
Yeah.
retraction. That's the main thing. I think in a way, Dolench approach is a subtemporal approach, but you are relaxing the brain, and the deep brain becomes a shallow space.
Yeah.
Okay. If you do just subtemporal approach, it's very tight.
Yes.
That's my opinion. I mean, if you do it and you're successful, you have good results, I
Well, it
congratulate
depends
No,
also on the size of the tumor.
I-
If you have
Huh?
a small to moderate sized tumor in the middle fossa, subtemporal can be enough. But if you have an extensive tumor, like some of the stuff that you alluded to, Mustafa, then yeah, I would do the pretemporal anterior petrosal approach.
Yeah,
this is the best choice.
yeah. In reality, I mean, we call it transcavernous, but it's not sometimes true transcavernous.
Yeah.
You
Yes,
just
it's
need
true.
it's just pretemporal approach at the
Yeah.
end. Extradural approach initially, and if necessary, you can turn into depends on the condition and tumor location, etc. But mainly extradural approach, and extradural approaches, patients feel much better after surgery.
Yeah. I agree. Thank you, doctor. Thank you.
You're welcome. Thank you.
Abujan,
there
there
any
is one
question?
question. Yeah.
Okay. What is the difference between petrosectomy and transpetrosal approach?
Sorry.
There's a question from the attendee. What is the difference between petrosectomy and transpetrosal approach?
Oh, I mean, petrosectomy is the same thing. I mean, it's just this wording. Petrosectomy, you can do posterior petrosectomy, anterior petrosectomy. I was referring to the anterior petrosectomy because trigeminal schwannomas will erode the anterior petrosal bone, and sometimes I call this autopetrosectomy because it's already done by the tumor. Transpetrosal approach, you can do anterior transpetrosal, posterior transpetrosal, or you can do complete transpetrosal combining anterior and posterior. So trans means going through the petrosal bone. Petrosectomy is the same thing, you know, is this I just wording.
Any comments from the other attendees? I want to thank again, and one of attendees asked about the external drain to relax the brain. Do you use lumbar drainage, Mustafa Baskaya?
Yeah, it's in the young patients with the full brain. I like to use lumbar drains, especially in the dominant hemisphere, for two reasons. One, relax the brain, but you should be careful not to drain too much because also you are retracting. Sometimes you can cause transtentorial herniation. And also, I use a lumbar drain to prevent the postoperative cerebrospinal fluid leak in the postoperative period. So two purposes: relax the brain perioperatively and postoperatively to prevent the CSF leak. It's much easier if you put the lumbar drain during the surgery under gel anesthesia than if patient leaks during awake and local anesthesia, very discomforting. Not every case I use for elderly patients, slack brain, non-dominant hemisphere, I wouldn't use it.
Thank you, sir. And I want to thank again, and I want to